Part two.
They vary tremendously when they come in for treatment. Typically, when a person who actually has DID comes in for treatment, they tend to come in with reports of severe crushing depression that hasn't responded to any medications or previous trials of psychotherapy. They often have post-traumatic stress disorder. They tend to be aware of that. They may have a substance abuse problem. They may have an eating disorder. They have problems with sleep. Every so often, there are people who come in and they're aware, or they think they are aware of having dissociative states, but that's actually not so common. Although with all the social media that's out there now, more people are sometimes coming in, at least in my experience. I've been in the field for about 30 years. And I do have some people who have come in and said, I think I have this. And I proceed to do, a standardized assessment and find out if it's accurate or not. They're often very embarrassed about their mood. Their mood changes, but even more importantly, the lapses they have in memory. Imagine you or I, we don't know somebody who greets us on the street, who obviously knows us, calls us by name, and is referring to a conversation or an interaction we've had. It would be mortifying. They have that happen a lot. And so it's embarrassing, and they try and cover that up like anybody else. Anytime anybody else covers up something we've done that feels embarrassing.
As you mentioned, there are tests. There are ways that you determine whether people actually have this disorder.
Tests.
How do you assess patients for dissociative disorders? And then what kinds of treatments are available?
Sad to say, but most mental health professionals have not been trained in assessing dissociative disorders. They don't even know that much about dissociation. At the start of the hour, you talked about how there's some controversy about dissociation and dissociative disorders. And so that's one of the factors that leads to many graduate programs, medical schools not doing training about it. So first of all, a person would need to go to somebody who's had training in assessing dissociation.
Yes.
And I'm currently actually writing a book for the American Psychological Association on assessing dissociation. It is the first book that's ever been written solely about the multiple ways you assess for it. So that shows you how far behind our field is in really learning about assessing dissociation. There are a number of scientifically validated self-report questionnaires that a clinician could use. There are also standardized evidence-based interviews, structured clinical interviews for dissociative disorders. And hopefully a clinician would use one or more of those tools to make an accurate diagnosis. It can also be done without those tools, but then there's more errors. There's just more errors. Like when doctors do blood tests, that you've got a greater chance of getting an accurate diagnosis. And the same thing with mental health conditions, especially this one, because it really can sound like and seem like different disorders.
And then what are the treatments that are available?
It tends to be a longer term, trauma-based, trauma-informed treatment, where there's 3 stages, roughly speaking. That when the client first comes in, they tend to be struggling with profound depression, like I mentioned, but also many of these folks have a lot of self-harm, like cutting or burning. And they often are, in research terms, the research is clear, they are some of the most suicidal clients in the mental health field. So there needs to be a lot of stabilization. So they need some help. For example, I talked about problems with sleep. If you don't sleep, you don't do well in the day. But because nights were often times where trauma occurred, or they have nightmares, they're terrified of sleep. And they're hyper aroused. Their nervous system is jacked up because of all the trauma and the flashbacks and the nightmares. And so helping them get their sleep regulated, helping them get any self-harm or suicidal thoughts under control, helping them learn not to dissociate so much they're what's called losing time. They're having those gaps in memory. So you're basically doing a lot of teaching tools that help the person manage their symptoms, function day to day. And also another thing is addressing profound shame, self-hatred, and taking it out on themselves, basically. That's through the self-harm, for example. And so you do a lot to try and educate them about the impact of trauma so they don't feel like they're just, this evil, awful person, that they understand the things they're struggling with are symptoms. Anyway, all of that is stage one, stabilization and safety.
Okay, I can't do the whole thing. It's almost an hour long, or half hour long, sorry. Um, it is on YouTube and it's called What is Dissociative Identity Disorder with Bethany Brand, PhD. And again, it is through the American Psychological Association. There are legit facts in here that will be very helpful to you. And I will put a link below in the comments so you can continue to listen to this if you found it helpful. Please share it. It needs to get out there because of the stigmata of people faking this disorder is just way out of control. Loves. Bye.